The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, rural ructions.
What I'm really worried about is the quality of care within the organisation.
That's Associate Professor Rex Prahbu, the Executive Medical Director at Swan Hill District Health in rural Victoria, and I'm presenting him with a difficult scenario.
If you've lost trust in that hospital, that's your home hospital, where do you go for help?
In today's scenario, your rural town has a 30-bed medical ward, a small paediatric ward, maternity unit and operating theatre. It operates a very busy emergency department. There are 2 independent GP clinics in town. None of the GPs work at the hospital and each of the practices are fierce competitors. The medical services, surgery and paediatrics are serviced by specialists from the regional hospital who visit for a few days each month. You struggle to recruit sufficient doctors to staff the emergency department. I start by asking Dr Prahbu what issues this scenario raises.
This scenario is really close to my heart, having found myself in my first substantial role in Swan Hill, and the issues are no dissimilar to what was the real situation there. So at the coalface, you could see numerous issues of workforce and quality of care, but it also speaks about broken culture, probably broken relationships or trust between the hospital and the general practices. What I'm really worried about is the quality of care within the organization, no matter what the external circumstances. The impact is always on patients, and our roles as medical leaders is to ensure that the best outcomes are given to our patients. So workforce sustainability, financial position, how long is this going to go? We're spending a lot of dollars on premium labor, the ability of the organization to deliver contemporary care, as well as the ability to innovate. More so over the reputation of the hospital in a small community. And this is at the core of my heart, because in smaller communities, there's one destination to go to. And if you've lost trust in that hospital, that's your home hospital, where do you go for help? And it's so vital to build confidence among small communities about the care that's provided to them. And, if there's lack of integration between the hospital, the independent GP clinics, this limits a lot of opportunities to create shared staffing models. Operationally, I think these independent GP clinics, they might be competing with each other for the same talent pool that's coming to the town, and you then struggle to recruit and retain doctors, because at the end of the day, 95% of our workforce pipeline comes through the hospitals. And there's a lost opportunity there of translating these doctors and integrating them to general practice. So, and again, depending on how the clinics operate, there could be fragmented service delivery.
Can we look at this issue of integration? So often the rural hospitals are seen as branches of the regional hospital, and regional hospitals don't have GPs visiting them. So can we talk about this integration between the local general practice and the hospital? Can the GPs admit patients?
Absolutely. And there are models of integrated community plus hospital care that's really well developed in Queensland. But in the Victorian context, there are a few smaller health services that have been forced due to market failure to get into general practice as a business and core to maintain that service continuity. But if you look at models that where market failure has not occurred and you've got 2-3 private practices in town, and general practice is a private practice in itself, you have that opportunity of engaging that entire loop of care. So the loop of care I talk about is you see the patient in general practice, you know what's wrong with them because you know them really well, and you know what could go wrong with them. They end up with that acute point of care. If you've got admitting rights for those GPs, they can provide that acute care. Now, 2020 is after COVID, telehealth is widely available for specialist support. And then you close that loop of care by seeing them in the community again after discharge. Especially with things like palliative care, wouldn't you want your doctor that has treated you for a lifetime to look after you when you're dying? And it's more the emotional element that, we can really develop patient experience from. And by working together, there's no loss to the system.
So this idea, I guess, is the basis of the concept of rural generalists who are often based in general practice but have special skills like obstetrics or anaesthetics or paediatrics or even surgery. And they work part-time at the hospital and part-time in general practice. Tell us about these rural generalists.
If you'd want to define a rural generalist, I would say it's a medical practitioner who's trained specifically to address the needs of rural and remote communities. So, they have comprehensive general practice training, but they also have emergency care training, and then they might have additional skills in a subspecialty like anesthetics, obstetrics, palliative care, internal medicine, and that can be really diverse. There's currently 2 colleges that train rural generalists. There's, Royal Australasian College of General Practitioners with its rural generalist pathway. They call them RGs, RACGP-RG is the fellowship, trains general practice with the skills to manage, in smaller towns and in rural regional areas, as well as the College of Rural and Remote Medicine that specifically, obviously trains rural doctors to train in rural generalist medicine to face the unique challenges of rural healthcare delivery. So these are the 2 colleges in training, and they produce fantastic graduates out of the program that are able to manage, have a diverse skill set for a smaller rural setting.
So how long does the training take? I mean, they've got to do general practice and then they've got to do obstetrics or anaesthetics. How long does it take to become a rural generalist?
Yeah, look, I think from, probably the journey from medicine would be 10 to 12 years. You finish your 5 to 6 years medicine degree, internship for a year, or now it's going to be 2 years soon. And then, a year or 2 of core generalist training, as they call. So, the adequate exposure to pediatrics, adequate exposure to obstetrics in those core years. And then you do your general practice training, and obviously there's a bit of diversity in how much time each college requires them to do so. With the ACRM, the minimum is 6 months, whereas with RACGP, the minimum is 2 years. And then there's an advanced skill year where they, specialize in that subspecialty that they are interested in. But then they come out and, they have to undertake some form of consolidations of skills as well. They might get the advanced diploma, but then how do they translate those skills to the capacity and capability of that hospital that they're going to then embed their practice in? And that's the consolidation period of at least 6 months, but sometimes depending on, part-time and, full-time, because sometimes they might consolidate 2 days a week in general practice and consolidate their skill for 2 days. So it might go up to 12 months as well. Yeah, look, I think that's the duration of training, and there's obviously ongoing training and education that's required from time to time, and workshops as part of the training program. Yeah.
Some of these rural GPs work in very small rural communities. How do they get supervision if they're going to be trained? Is there an opportunity for remote supervision or mentoring?
There are very unique training models now, and I specifically speak about the remote vocational training scheme. And Swan Hill had the benefit for the last 2 years to host around 4 of these trainees. Now, it is a specifically registered regional training organization, but it only trains a small number of trainees every year in the country. So these spots are highly coveted. So there's around 40, I think 35 to 40 remote vocational training positions. And the model is excellent because you do have to have an on-site supervisor, but your primary supervisor can help you through telehealth, through remote supervision. And they've developed significant workshops. So they do have, just like you're going to a uni degree where, at the beginning of the semester, we workshop all the skills that you require. And there's some period of time where they'll have to complete some formal modules. The supervisor comes into practice sometimes face-to-face, spends a couple of days with them, make sure they are safe in practice, they have the support that they need, they can phone a friend when they need to. And, these models are effective really in really remote settings. But, in traditional, MM4 and below, you do have the normal support that's required for supervision. So if you've got an advanced skill anesthetics, you do need a specialist anesthetist to be the primary supervisor, and your secondary supervisor can be a GP anesthetist. So these models are quite effective, but the colleges are really open to making sure that they don't lose training opportunities. So the colleges are open to doing half in a bigger hospital, half in a smaller hospital, as long as they feel that the trainee is feeling safe and the patients under their care is safe. There is flexibility in that kind of getting those posts accredited. So yeah, there are remote supervision models, but the traditional hospital-based rotations, do need a supervisor on site, yeah.
I guess from a clinical governance perspective, this issue of scope of practice, these doctors, as you say, have done a year's training perhaps in anaesthetics. They're not a fully qualified anaesthetist. How do you make sure that they work within their competence?
Most of the time, the proceduralists usually work within a service capability framework. So most of the smaller hospitals, don't do complex cardiothoracic surgery. They do lumps and bumps, gastroscopies, colonoscopies. There might be that case of emergency laparotomy. And so if you think of anesthetics, then you've got your training. So what training they've completed, they usually get a certificate of advanced specialist training, and that's recognized by the Joint Commission. Now it's called a Diploma of Anesthesia by the colleges. So then they've got their consolidation skills, their fellowship. We also look at their logbooks and their recency of practice, because for several of, say for example in anesthetics in Swan Hill, most of our GP anesthetists, we make sure they are skilled to undertake pediatric anesthesia of low risk level. So, we have policies and procedures on what constitutes low-risk patients. We then look at the safety of the procedure and the complexity of the procedure. And we look at the safeguards of what's there. For example, if we are doing ENT surgery, we make sure we've got the ENT surgery there, the ENT surgeon there for the next day as well. Mm-hmm. We make sure the general surgeons and the ED generalist team know how to manage complications when the surgeon's gone away as well. And we make sure that when we call for help, we know that there's going to be help immediately, because we know this is the setting that we're operating in. So we look at those aspects, but there might be specific training requirements that the local facility might say is mandated. So for example, with my obstetricians and my anesthetists, all of them need to do neonatal resuscitation, because, whether you're an obstetrician there, whether you're the anesthetist, or you're an ED-GP, when you know there's going to be a crisis, say, for example, there's going to be an obstetric crisis, and if the mother's having a PPH, the anesthetist is managing the fluid, right? And the obstetrician's managing, obviously, the delivery and, managing the complication. And then you've got a GP who comes there and holds the baby and manages if there's any resuscitation. So you need three hands in that situation. So all of my rural generalists, the mandated requirement in Swan Hill is to ensure that they have neonatal races on twice annual basis, because we do know that It doesn't come so often. It's a skill that we need to have, and we need to be ready when it happens. We do have 6 or 7 neonatal resuscitation situations in a year, so the volume is low, and that's why it's important to do it twice a year so that you feel confident, when crisis hits. Yeah. So that's the other way we do it. We also limit their practice to an extent depending on the capability, and we have clear guidelines, say BMI 40, really complex comorbidity, then that patient, depending on the ASA classification, they are referred on to higher levels. So that's the way we go around managing their scope of practice. Yeah.
One of the big challenges in a rural town, as the scenario implied, was GPs get very precious and protective of their practice. How do you get the GPs to be interested in working in the emergency department at the hospital?
I think it starts with real crucial conversations on how do you role model to get the next generation come and work with you. And there's been a generational shift in medical training and what the next generation sees its role in general practice. Not every doctor, and this is case-by-case basis, you might have the doctors that are comfortable and happy doing 9 to 5 in a general practice setting, but you might have some who are aspirational that want to have a bit of acute practice in their day-to-day diversity. And so then how do you channelize that energy to give them that opportunity to practice that diversity of scope within the capability of the organization, and then use that person who's the supervisor as a role model to the trainees coming in and say, look, general practice can be as so rewarding, not just sitting in a practice, but can be 2 days doing mental health in Headspace, can be 2 days doing indigenous health, could be a week in anesthetics, could be that diversity. So each one's a case-by-case basis, but if you have more role models in those places, then your juniors, really look at, I want to be like Dr. X. I want to have the lifestyle of Dr. Y. I want to do skin cancer for 2 days. I want to have a 4 days work-life, environment, and that's possible.
So a number of rural hospitals are looking at the single employer model, where the hospital starts putting the GPs effectively on salary and says, look, don't worry about your income or your viability of your general practice. Let's integrate hospital and general practice as a single employer. Any comments on the viability of this idea of single employer model?
I'll be a bit controversial here, and this is, having, led a very successful model in Swan Hill where I've not been a single employer in terms of the same contract being translated as you train, but we've built a single location where you can train with us throughout from third year med school through GP fellowship and that advanced skill. But we give you different contracts at different stages of your career. Just because, as I said, general practice is a private business and Medicare billings control what revenue you can bring in. It's an activity-based fund at the end of the day. Right. And so, smaller general practices are losing traction with 1 or 2, if there's 1 or 2 GPs, it's no longer viable. It's only viable when you have scale. If you have 6 full-time GPs and you keep your administrative, efforts tight, you keep your good control on your outgoings, you can make a profit. But you need that scale. And therefore, it's important to identify that's the market at the moment. And we've got to obviously tailor to be sustainable. We can't go broke by, shifting money from this side to the other side. We have to ensure that there's opportunities to thrive. And there could be mediums to, for example, if a GP is working in a hospital setting and is doing a fractional VMO role, that can be tied to salary packaging, and that's an opportunity for them to, save on tax.
Yeah.
So that's a carrot to kind of say, okay, work 4 days there, do an on-call here, do some teaching here, there's some opportunity here. And I guess where market has failed, people have gone into the single employer model. For training, it looks great because I think for the trainees, it's a great opportunity if they can get into a single employer model role, is that it gives you that continuity, it gives the ability to take parental leave and all those opportunities that you get. But the other benefit of keeping someone in the same place for a long time and train them is that the likelihood of them staying after that is higher. So in that sense, yes, single employer model, but is it sustainable? Probably not financially. So it is a complex field, but you have to keep the place equitable to all, and that's our role.
Coming back to the clinical governance questions, one of the challenges is in rural towns, the number of adverse events is very low. Even in a reasonably busy emergency department in a rural town, still the volumes compared with a major city hospital are small. How do you make sure that you're providing a high quality service when the volume of adverse events or major adverse events and incidents is so small?
We do see, just by scale, in a smaller place, you will see lesser incidents, but you also have to imagine that the support on hand to review these incidents is much lesser as well. So most often it goes to the medical director to give the expertise or be involved directly as the keeper of good clinical governance in these places. And so despite the challenges of low volumes, sometimes you might be surprised that, it takes the medical leader to drive clinical governance. But, I think the aspects of reviewing your protocols, you might be surprised. You might walk into the ward and see the observation chart has not changed for 10 years. Yeah. And here we've got latest guidelines and evidence to say, the calling criteria is much lower than what it was 10 years ago when it comes to calling for med calls and code blue. So those resources might be lacking, and that's why there's the continuous improvement of key performance areas doesn't change, because in the public sector we're still benchmarked with the best. So medication safety, clinical incidents, patient feedback becomes good source of information, ensuring you may not have an M&M in craft groups, but you might have a whole of organization M&M where everyone contributes equitably. Yeah. So in Swan Hill, I also get the heads of dietetics, the heads of occupational therapies involved in the M&M, and obviously a core set of minimum representation of each doctor from their subspecialty as well, to ensure that everyone's contributing to that quality improvement. And sometimes you might want to, because it's a small group of people you're working with, and when you have serious incidents, there's obviously this emotional response as clinicians, as human beings. So it's sometimes good to get external independent advice, clearing out all the emotions around the situation. So, I tend to sometimes, in some situations, if there's 2 or 3 members of the team, they're all members who are employed by the organization, it's better to get an independent, come hear their point of view, review the situation in an objective measure and give an objective point of view, how shall we improve. So that's an aspect that you would probably see in smaller health services. But in terms of those benchmarking, in the Victorian health system, even the smaller health services, the regional, are benchmarked against each other. So there is some kind of, quality of care. And then our statement of priorities of what we have to achieve every year is an important factor as well.
It's so dependent on the culture as much as the compliance. Because incident rates are so low, compliance can be very hard. Whereas the culture is something that underlines good clinical governance.
Yeah, absolutely. And it comes from the top, isn't it? I always think that as a medical leader, you have the ability to influence a sphere of people. And that could be, you're the doctor in the room and most often the only doctor on the executive table. And you have that realm to influence in a very collegiate manner to get the best outcome from the team of them. Ask the crucial questions, but in a very collegiate way.
Thank you so much, Rex, for your time this morning. Did you have any final comments or observations about the future, I guess, of clinical governance in the rural setting?
I think, my aspiration, being a medical leader, moving into rural and regional towns is, as you see, there's so many positions vacant in the regional space. And I really want leaders, the doctors that we're training, the specialists that we're training, to take a leap of faith and come to the country, because we do need good leaders there to set the tone. And even if it means the start of your career, spend 5 years, 10 years shaping the shape of health services in the country, it could lead to such tremendous impacts, because we've learned the science, we've got the peer network, we've got the support around us. So, what's holding us back? And it's a good lifestyle, cost of housing is cheaper, school is not so expensive. There's a lot of opportunities for family to grow. Yeah, and I think taking that leap of faith is what I would try to advocate the next generation to do.
That was Associate Professor Rex Prahbu, the Executive Medical Director at Swan Hill District Health in rural Victoria. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.